Good afternoon, everybody, and welcome to this Health Foundation webinar on international healthcare responses to the pandemic. I'm Jennifer Dixon, and I'm pleased to be your chair here today. Very important, isn't it, that we learn from one another on what has been one of the biggest acute challenges faced by health and care systems in our lifetime, how healthcare systems responded to the pandemic, why they did that, and importantly, what lessons are there for doing better in future are the key exam questions we're going to be looking at today. It's obviously a huge topic with many parts. Seeing the wood for the trees is going to be absolutely critical. So I'm really delighted to say we've got a truly stellar panel here today to help us see the wood for the trees and find the most important contours. So I'm just going to introduce them to you now. First, we have Mark Pearson, who is Deputy Director at the OECD with Health in his Brief. Through the pandemic, he has supported countries in their crisis management and compared their responses. And before joining OECD, Mark worked at the Distinguished Institute for Fiscal Studies here in London, didn't you, Mark? And has been a consultant for the World Bank, the IMF, and the European Commission, among many others. So welcome, Mark. Then we are delighted to welcome Caroline Pearson, another Pearson, but no relation we hear, who leads a healthcare strategy group at the University of Chicago, providing independent, objective research on healthcare. Caroline has a long distinguished history in analysis in healthcare, and her recent work has focused on the international responses to the pandemic, which we're going to hear about today. And then we have Joseph Figueras, who is the director of the European Observatory on Health Systems and Policies. He's a on healthcare, including the Healthcare Commission, the World Bank, and more than 40 countries in the European region and beyond. And before he got very grand, Joseph and I knew each other when we were humble PhD students working out of a portakabin in the London School of Hygiene and Tropical Medicine. So it's always a delight, Joseph, to see you again and hear what you have to say. And then last but not least, we have our very own Hugh Alderwick, who is Head of Policy here at the Health Foundation, responsible for all our analysis and research on the NHS and social care. And before us, Hugh was a Harkness Fellow. Subtext, for those of you who are interested in Harkness Fellowships, please apply. It's a great program. And Hugh spent a year at the University of California, San Francisco, and at Berkeley University. And before that, he was a senior policy advisor at the King's Fund, so a very distinguished pedigree there too. So welcome to you all. So what we've got is we've got just over an hour, haven't we, until 2 o'clock. And what we're going to do first is have some short presentations from Mark, Joseph, and Caroline in that order. And then I'm going to ask you to respond to that. And then we'll have a Q&A. And please ask some questions in the Q&A, and we'll get to them as much as we can in the open discussion. So in the presentations, Mark is going to cover the impact of the pandemic on OECD countries and give us an initial assessment about how resilient he thinks the different healthcare systems have been. Joseph is going to give us a brief summary of some of the common measures that European health systems took to respond to the pandemic and reflect on the lessons learned. And Caroline will also look at the findings from her analysis of healthcare system responses in 5 countries and what we can learn. And as I say, and then I'll ask Hugh to give us a roundup and his reflections given a UK perspective. That's all going to take 40 minutes, and then we'll have the discussion. So just before we start, a few housekeeping bits. The event is being recorded. It will be on our website within 24 hours, so please tell your friends or watch again. As I say, please do ask questions. Lots of you are interested, lots of you are attending, so please give us the benefits of your wisdom by asking questions in the Q&A box at the bottom of your screen. I'll draw on these in the discussion. And if you like someone else's question, you can upvote it by clicking on the thumbs up icon, and that therefore it'll get to my attention earlier. And thank you for those who've already submitted some questions. I've got all these, rest assured, and we'll get to them. And finally, for the Twitterati, please use hashtag THF, the Health Foundation THF International Lessons, and please tweet away. Okay, so let's start, I think, and let's kick off then with Mark, who's going to make us some opening remarks here. Thank you, Mark.
Wonderful. Thank you so much, Jennifer. Really, really glad to be here today. Let me get my presentation up and running. There we go. It says, yeah, there we go. It's obviously, this is going to be a topic that I think we're going to spend our next few years talking about, aren't we? There's going to be an awful lot of discussions on this. We, in fact, at OECD, actually developed a framework for resilience that we've been using, not just in health, but across all sorts of areas of the economy, because we developed it after the global financial crisis, the other great shock that we've had to deal with in the past, well, in the 21st century so far. And in fact, I'm not going to talk in detail about the framework, but I will just very briefly say it was developed, actually, it's the US Army Corps of Engineers framework that we adopted, because one thing about the military is that they do think about crises and worst case scenarios in quite a structured way. And basically what that does is that it looks at 4 domains: the physical, information, the cognitive, and the social. And in each of those areas looks at how, whatever you're looking at, how resilient the system is in 4 different event stages. So preparing, and we already know we did that badly in the health area for COVID, how you absorb the crisis, absorb the shock. And that's something that I'll talk a bit more about today, of course. But then 2 very, very important stages that lie in the future, which are the recovery and the adaptation. And there we can't say how resilient our systems are yet, because we still haven't reached that point, but we have to. That's what we need to be doing. So I'm not going to say any more about that framework. No doubt it will come up occasionally in the discussion. But as I'm the first speaker, let me start by just doing the obvious slide, which is how countries have actually done, not looking at the COVID recorded deaths, as we all know, loads of problems with them, but instead looking at the excess mortality. I don't know if you UK viewers think that the UK is doing better or worse than you'd expect. It's doing slightly better than the OECD average, but that's largely because the Americans did so very, very badly. But it is doing worse than most of Europe. You know the numbers, 5.8 million deaths globally, 13% more people died in OECD countries than expected. Pretty shocking numbers, however you want to look at them. So I suppose that's the best way that we can summarize the outcomes across the different countries. Looking at particular reasons why we end up to those outcomes, obviously a huge number of different aspects that we need to look at. But one that I really do want to pick up on, because I know it was highlighted by some of you in the questions you sent in before this seminar started. You know, the resilience of the system isn't just about the health system, it's about society as a whole. And there are massive differences in mortality due to differences in inequalities. And what I've got here in the charts is people in the most deprived areas compared to the least deprived areas. And on average in those countries where we've managed to find studies, 80% higher risk of dying from COVID if you're in the most deprived areas. You'll see there, generally the UK countries do worse than that, up to 2.4 times the odds ratios in England and Scotland. Of course, that's just one way of looking at inequalities. However you look at it, there's a clear impact from inequality. You'll see on the right-hand side, the odds ratios, you know, 40 to 80% more likely to have died if you just look at income. If you look at ethnicity, between twice and 2.5 times as likely to have died. And there also seems to be an impact on the foreign-born income. I don't think that surprises anyone, but if we're talking about resilience, it isn't just, of course, about health systems. It's about how people live and the inequalities in our societies. Other issue I really want to pick up on in how we've coped with this, because it's going beyond that mortality issue. Mortality is an obvious measure to look at how countries are doing, but obviously there's been a big impact on morbidity as well. And you know, I think it's the mental health impacts which really scream out when you look at the data. You know, this is the national estimates of prevalence of depression or symptoms of depression amongst adults. And you can see these enormous increases, obviously partly caused by the stress of the lockdowns, partly caused by the stress of the disease, partly, of course, caused by the neurological impacts of having the disease. If I've only got the 2021 numbers for about 5 countries, but for all 5 of those countries, the numbers are even higher than in 2020. So this is an absolutely huge impact. And we know, of course, from the Commonwealth Fund survey that was done last year, that in the UK, in the US, we're talking about nearly 2/3 of the people who are reporting needing mental health during the pandemic were being unable to obtain such care. That was the survey done between March and May 2020. And I think that's a big issue in talking about the resilience of health systems that will need to be measuring, need to be taken into account. But lots more that we could say about the different ways that the pandemic's been impacting us. Of course, when we get to health systems, one obvious way to look at how well health systems or how much health systems have been affected is to look at things like waiting times. We do try and collect comparable data on waiting times across countries. Not easy. In fact, when you get into it, there are very, very many different ways of defining waiting times, but these are standardized numbers that you have here. And you can see in every country, with the possible exception of New Zealand, you've seen pretty large increases in waiting times. And that goes, of course, for the UK as well. One of the things that's happened in this crisis is that the countries which traditionally don't have waiting times, or claim that they don't have waiting times problems, have seen them appear. So, for example, in France, and here I'm actually quoting from personal experience, you never used to have any delays if you wanted something like a colonoscopy. At the moment, 5 months delay. Right now, that means that if we're looking at some of the indicators we traditionally look at different systems and say, oh, there's no waiting times in these countries or whatever. Well, one of the things that COVID has done is that it has blown that up a bit. I mean, we really do have waiting times appearing in some countries which traditionally haven't. So whilst we measure them in some countries and tend to focus on those countries, don't believe that it's not actually impacted other countries very much as well. I only had 7 minutes for this presentation, and so I'm reluctant to go into huge detail on workforce, but there is no doubt, I think every study that we've done, every study that anybody's done, has defined the great constraints in health systems has been the workforce. People talk about beds. Beds aren't really a huge issue in the short term, but easily overcome. It's personnel that has been the big issue. You know this chart. I suspect many of you. The UK has particularly low numbers of doctors and relatively low numbers of nurses. That has been, I think, a constraint in how well the UK health system has coped during the crisis. Obviously, what we're seeing at the moment, great talk about the Great Resignation going on. The Great Resignation that there is no evidence for outside of North America, except in the health and social sector, where we do see signs of greater resignations going on from people working in those sectors in a number of countries. So, I mean, here we are, we've identified the most important thing that has affected how well countries have managed to respond in many respects to the crisis. And we find that things will be much more difficult in the recovery and adaptation stage of the crisis than they were even during the absorption stage of the crisis. I want to just finish with this last slide. We'll no doubt get into many of the other issues in the discussion, which is just talking about how much it will cost to improve the resilience of our health systems. Internationally, the huge amount of focus is on pandemic preparedness and response. For things like vaccination, infection control and testing and so on. Yeah, I think we could do with spending more on that, even in OECD countries too. Obviously, a lot more is needed in low and middle income countries. But actually, I don't think that's the main barrier to improving the resilience of health systems, or at least it's certainly not the only barrier to improving the resilience of high income health systems. We've seen problems with the physical infrastructure of health systems. We've seen massive problems with the digital infrastructure of health systems. We think that about 6% of GDP per year is needed over the next decade to try and improve that one in an average OECD country. But the biggest extra expense needed by far will be on staffing. And again, for the typical average OECD country, we're reckoning nearly 1% of GDP will be needed in order to get up to a decent or a level of staffing that gives us some confidence that we'll be able to cope with the next pandemic rather better than this one. Lots more to say, Jennifer. You know, such a huge topic. I'm going to have to stop there, but I look forward to the conversation. I'm sure we'll get into many other issues when that gets going. Thanks very much.
Thank you so much, Mark. And can I just ask one thing before we turn to Joseph? You started off by saying that there was some kind of resilience index that the military had used. Was it the US military? Is there a kind of work to assess how countries have fared using such an index? Is there consensus that such an index is useful, and are we kind of looking at how countries square up against this and therefore what they need to do in future, or is this just too early at the moment?
It's something that countries are wanting to speak about. So it's actually a framework. Yeah, and it's the US Army Corps of Engineers, that framework. They developed the framework. Everybody before the crisis says, yeah, that looks like a good framework, doesn't actually have much impact on what people do. So obviously now in trying to assess health, the response of the health system to COVID, we need to turn that into indicators in each of those areas. And that's what's going on at the moment. We have lots of discussions going on with countries on what sort of indicators reflect accurately the different stages and the different domains that we'll be looking at in that framework. So yeah, that work's started. But equally, you can imagine that people are already thinking, countries are already thinking about what their results will be, and that's maybe affecting a little bit about how they're reacting to that framework. But yeah, that work started.
Yes, because you could imagine a sort of countries having a rash of inquiries, at least some sort of analyses going on. And if people are comparing apples with pears, it would be easier, wouldn't it, if there was some recognizable set of indicators?
Absolutely.
It could be all over. Okay, we'll come back to that. Thank you very much, Mark. Let's go on to Joseph then. He's going to give us a little bit more of a picture on the European side. Joseph. Thank you.
Thank you. Thank you very much indeed. What a pleasure to be with you, Jennifer, and such a panel of learned colleagues. Perhaps following from your question, and Mark, maybe perhaps we can share with colleagues here that the OECD and the Observatory are now working in such a framework, and some of the measures through funding from the European Union, and we hope to have England as well included in that somehow. And the enormous complexities, actually, we can talk perhaps during the debate, Jennifer, about differentiating the measure of resilience with the measure of performance. It's not a straightforward issue. It's a very interesting debate there. I hope you're seeing my slides. So what I like to do, and I hope complementing very much the presentation of Mark, is to give you a sense of the forest, of the wood, you're saying, Jennifer. So what is the wood? What is the kinds of strategies that we feel that have helped to strengthen health systems resilience in different countries, and how we can use those to build back better? I'm aware that the building back better in the UK in England has a particular set of connotations. Here is basically what are the lessons. I'd like to start with highlighting some of our products that you can see here. One is the COVID-19 Health Systems Response Monitor we do with the WHO and the European Commission that takes country by country of the European Union, including the UK as well, and monitors the kinds of responses by different parts of the health system. Then we produced a number of products. Actually, I'm very happy, and Mark, we should say as well, that since 2017, the OECD and the Observatory in the country health profiles started using resilience as a measure of evaluation well before the crisis. And the first product you see here, Strengthening Health Systems Resilience, is the framework we developed around measuring and assessing resilience, which was done actually also in 2017. After that, and based on this research, we've been doing a number of EuroHealth, our journals, looking at aspects of governance, human resources. And the last one you can see here with the stars of the European Union actually was presented to ministers in the presidency conference this January, because of course, one of the lessons there that we're learning is that European Union countries are working much more closely in this idea of the European Health Union. So we see major changes in international governance, which I hope they're going to go beyond the area of the pandemic into other areas of health systems. Finally, on the right, we will share those products, some of these products in the chat, is a measure study that I'm going to use as a basis today to highlight what Jennifer was saying about the major strategies that show resilience in some health systems. A preliminary set of points here. COVID is only one shock, like many past or future ones. And it's not that surprising what we heard. It's not that surprising. Mark already pointed out that very nicely in his numbers. Human resources, problems, shortages, problems of equity, many others that were there have been heightened during the crisis. So as I said, I'll look at these health systems and strategies, and one important lesson today is there's been a silver lining. There's been a lot of innovation, and the question is, how do we harness and sustain this innovation? The first part of these 20 strategies, 9 of those were around leadership and governance. Those were essential for an effective response. Again, it's a bit frustrating to try to give you a sense of all of those within the time we got available, but perhaps to highlight one strategy that is not a strategy, is either there or not, which is effective political leadership. The high-level political leadership explains lots of the successes as well as failures. In addition to a good strategy, in addition to monitoring, I think we learn a lot about transferring evidence. And these setups that in some countries existed already, is the SAGE example in the UK, or independent SAGE, to transfer evidence to policy. There's a lot of learning there. We can talk about that in a minute. Coordination, not only from the central to the lower level, but horizontally. If there is a moment that we had health in all policies, has been during the COVID pandemic. We've seen very good examples and less good examples of Prime Minister Office, Ministry of Health, National Institute of Public Health, police, army, social services, collaborating or not collaborating. The transparency, the ability to say, I don't know, or there's uncertainty, and communication has been central. Again, we can talk about some examples, transparency and communication. The ability to talk to civil society, no surprise again, and building them on board and getting therefore more buy-in has been important. And one of the areas, number 9 there, is the host of movements we have at the moment with the national pandemic, involving G20, involving a number of International Monetary Fund, trying to see how health, the One Health, goes international arena, and we look at broad governance approaches, and we talk about broad financing mechanisms. In some ways, the pandemic is reminding us that we have to give up some sense of sovereignty, part of our sovereignty, to the international level. The other area, and Mark has already highlighted that one, again, a bit frustrating to put so many words in a slide, but I hope that by looking at these words, then you'll have incentive to look at our materials and go in detail with clear case country examples, looking at the actual strategies. But basically, the 3 sets of strategies that were key is the ability to scale up existing capacity and recruiting, lots of innovation in that area. Very interesting what we're seeing around skill mix, around task shifting, around repurposing. Very good examples of using, for instance, pharmacists in a much more effective ways doing prescription, ways to bring many professionals for vaccination and testing, ways to bring within the hospitals, for instance, physiotherapists to work in intensive care unit for COVID patients, and so on and so forth. So really a lot of innovation, a lot of retraining, a lot of transformation. In many ways, one of the areas that puzzles me, and we need to look at and we need to learn more, is this quick transformation we've seen in all the health systems. Finally, the ability to protect the mental health, to give financial compensation to our workforce is fundamental indeed. And Mark has said that already. The burnout of our workforce, the levels of depression of our workforce, of stress, is the issue that is the highest priority to look at now. Next one here, I wanted to highlight something you know well, of course, that is not just, as been said, Germany, for instance, has been highlighting that the number of hospital beds was key in their success. I would argue here today that it's not only that, much more important than that has been primary care. We've got very good examples about countries such as Finland or Spain that had primary care on geographical areas that had a good integrated care were capable to deal with the COVID cases, reduce the pressure on hospitals, able to trace, able to support vaccination. And as important as that is social services. If some of the countries have failed in the tracing and isolation, has been less perhaps on the ability of test or tracing, but the lack of ability to support isolation, the incentives, particularly all those more vulnerable populations or vulnerable employment. Next one, again, I'm sorry, so many words in the slide. It's a very poor way to communicate, but just to give you a sense of the amount of innovation, again, on the delivery area. Scaling up, repurposing and distributing capacity, adapting or transforming service delivery. We see new pathways, not only for COVID and not COVID, but many other areas. A lot of that is going to be very important for the backlog. We've seen working with the private sector. Take Spain, for instance. 3 days after the pandemic was sort of declared, many regions took the private sector and integrated it into the public sector. So again, private sector could be one of the ways we deal with the backlog. The ability on those countries such as the Netherlands or Finland that had national information systems with intensive care beds and other beds, and the ability to move patients around made a huge difference to cope with the pressures. We've seen as well, I talked about the role of primary healthcare, but lots of horizontal coordination between hospitals at European level through the European reference networks of hospitals, where guidelines were developed very quickly without going to national level, but across hospitals. This is innovation we need to harness. And of course, the usual suspect, which is digital health. And on digital health, here is a slide actually that we have in this work we presented recently with the OECD on the country health profiles for the European Union. One of those is the use of teleconsultations. We've seen a phenomenon, we have lots of data on that, of increasing teleconsultations in most member states for remote management, remote consultation, supporting management and hospital capacity, as I mentioned. But the point I want to make here today is the point that in our summer school this year, which was virtual, the next one we hope will be live, we looked at, which was the use of digital health tools during the COVID pandemic. And we should notice that many of digital tools have been so effective were there. So it's not the technology stupid, as paraphrasing the famous Clinton campaign, is the economy stupid. In this case, it's not the technology stupid. What made the difference is the financial. The way that some countries manage, like France, Belgium, we supported them on that, change the payment system to pay for digital health, change the regulation, supporting the cultures and the changes, the quality. Of course, the technical infrastructure, we're investing so much on that, is fundamental. But again, the message, Jennifer, here is this ability to transform. What happened during the pandemic, we know what happened, that allowed changes in payment systems for digital, but also to be able to cover and address the demands of the COVID services that we need to look at and are key as one of the lessons of the pandemic. So I'll stop it here, hoping that I rest enough issues for the debate later. Thank you.
Fantastic. Thank you so much, Joseph. And I was at a UK Netherlands sort of learning thing from the Foreign Office yesterday or the day before, I can't remember, a long week. And one of the big things that came up there was this whole issue of not just agility in the face of a threat like a pandemic of healthcare systems, but spare capacity and the difficulty in paying for spare capacity when it seems like waste when there's no emergency threat. And in particular, the role of the state in subsidizing that spare capacity. And I don't know whether there's been that much discussion in your observatory and with countries about how to tackle this conundrum, because you can see, can't you, when the threat is over, people might go back to our bad habits in living in just-in-time medicine as opposed to building that capability. We're all frightened now, but we might not be frightened in a year's time. So can you comment on that?
Well, I'm interested too. Actually, I would have liked to attend that meeting, Jennifer. I find that very interesting. I'm not that keen on funding lots of spare capacity. Of course, we're talking about countries that are working at 80%, 90% of capacity, which is obviously too much and doesn't allow for any flexibility. But to me, it's much more the governance, the coordination, the ability to respond in primary healthcare. Some of the successes, I don't know whether Mark and the rest of you, Caroline, would agree, all of you here, but it's been much more the ability to coordinate, to respond. I would expect more capacity in primary care and integrated care as much as hospital capacity, and capacity to build these new facilities. That made a huge difference in the moments of the peaks, rather than maintaining a spare capacity on a regular basis. Yes, I would agree that we cannot go to these efficiency levels of 90% occupancy, because obviously in peaks are not efficient and become these efficiencies. I understand that, but I would not put too much emphasis on a spare capacity, frankly, but I may need to look at that a bit more.
Yes, so you're saying you think that agility is more important?
Yeah, in fact, the definition that Mark and we used as well for resilience is the ability to respond, to a shock. We're talking about shocks. So the ability, the flexibility, the management, the governance. Realize that of the 20 strategies, 9, that's our analysis, we may be wrong, were around the governance itself. Of course, there's a lot, but listen, it's not the spare capacity, by the way. One point, I'll let you go. One point is the human resources to fill this spare capacity.
Well, I was going to say, because you can't magic up.
It's pie in the sky. We have these huge turnovers. This is the real issue, not the beds. My friend, I mean, Martin is always talking that why are we using beds? We should be using chairs for hospitals rather than beds. Martin McKeon is all, I mean, beds mean nothing if you don't have staff.
So you can be as agile as you like, but you can't magic up, you know, consultant for physicians or nurses, particularly.
Exactly.
It's the issue, isn't it? And whereas on the public health side, you might be able to have international collaboration, share intelligence, so you don't have to go to your own country. You can't really do that on delivery of frontline care. So there is an issue, isn't there? Particularly with Mark's scary graph about where we exist in that quadrant, that bottom quadrant on, you know, low nurses, low doctors per capita. So message for the Treasury, I think, isn't that, Hugh, that we should... Thank you very much, Mark. Right. Thank you, Joseph. We'll come back to all that. Caroline, over to you now. Thank you.
Wonderful. Thank you so much. Well, I'm excited to be here with you today and to talk about some research that we conducted early last year with funding from the Commonwealth Fund. And, you know, we were really focused on specifically the delivery system. We thought that we had heard a lot about public health responses and policy and mask mandates and the various effectiveness of that. And we wanted to focus on how the delivery system had responded and built resiliency. And we did so very much through a US lens. I think the sort of premise of our research is we needed some international lessons learned. So you're not going to hear a huge amount of optimism from me about our own performance, but we certainly focused on issues we're seeing here and then looked to see where sort of best-in-class responses existed. These are the 5 countries we conducted in-depth interviews with health system leaders and government officials across 5 countries, and I think did a lot of literature review of many of the resources that Mark and Joseph have also made available. And I will say actually that while we did not focus on public health, I can't overstate the importance of the public health response in determining the environment in which these delivery systems operated. The reality of the situation is that in countries that did a better job of controlling their case rates, their systems were under less pressure. And a system under less pressure tends to perform better, and that's certainly what we saw in our study. And so the two really do go hand in hand, and I don't want to underemphasize that in my sort of focus on delivery. Here's the framework that we really saw coming out of our research, and I think it bears some similarities to that Mark teed up at the beginning. Preparation being tremendously important and something that we really observed much more prominently in some of the Asian countries that had recent pandemic experience with things like SARS. And those countries were not only had plans on the shelf and regularly practiced sort of pandemic responses, but I think one of the interesting things was that they were really able to recognize what was happening quickly. So whereas many European countries and the US I think were slow to respond and really got behind the 8 ball. Many of the countries that we saw in Asia were much quicker because of their strong preparation. Response, of course, we've talked about extensively, and that'll be a lot of what I address here. But I do really want to underscore this third piece because I think it's so important. We tend to focus on that immediate response. How do we move staff? How do we move patients? How do we begin to implement new protections in the hospital for infection control? But what has been one of the hardest things for the delivery system because of COVID is really the duration. And so how do we build a system that is not only responsive, but can maintain that response over what has now been a very long, challenging pandemic. And that, I think, as we think about the workforce issues, is one of the biggest challenges. So I'll talk about some of our findings across these 5 areas, which we really focused on. And you've heard a lot about the first one, and I think it continues to be the area of greatest concern for me at the moment, which is really staffing. And so, early on, we were very focused on the nimbleness of our staffing and the adaptability of the staffing. Some of what Jennifer and Joseph were just speaking of. How do we take physicians and nurses who are trained in one area and quickly retrain them to operate ventilators and to work in the ICU? How do we move workforce from a sort of COVID hotspot into other areas of the country, or into a COVID hotspots from other areas of the country? Those were sort of top of mind upfront. At this point, though, we in the US had very lean capacity. We have a system that has focused on limiting provider capacity as a way to try to control utilization. We don't do a lot of quotas or waiting times or anything like that. And so we didn't have a lot of extra capacity. And mostly systems responded by reducing staff to patient ratios and by asking staff to work longer and harder, typically with lower pay. We operate in a mostly fee-for-service system. And so actually at the same time that we were asking healthcare workers to work longer and take on more personal risk to themselves and their families, we also were cutting pay, eliminating bonuses, and suspending retirement contributions. And so, 2 years later, you've heard all the other speakers talk about the severe burnout problem that we are having in the US and that I think is really beginning to show elsewhere in the world as well. And, as we looked around at other countries, we saw lots of countries that did much better in terms of supporting the financial needs of their healthcare workers and being responsive in that sort of initial stage. We did not find yet a lot of lessons learned about sort of how to manage the mental health of that workforce and how to build that long-term sustainability. And the burnout issue that we're seeing internationally is the direct result of that, in my opinion. On access to care, we also heard themes about this, I think, from both of our other speakers, right? But we were really focused on how do we sort of manage 2 things concurrently? How do we address COVID surges and deal with patients who are very ill, but continue to let the system run for all of the sort of ongoing non-COVID care that we need? And again, this is a place where I think we've had sort of mixed success in the US. And we, in fact, now are seeing a lot of evidence of foregone preventive services that are leading to later stage cancer diagnoses and sort of a lot of other morbidity and mortality effects not directly related to COVID infection itself. What we saw here really was that other countries with more centralized systems, I think, did a much better job of establishing a plan about how can we set up facilities at different levels of severity so that we've got sort of high needs COVID patients in one area. We send folks that just need monitoring or oxygen, but less intervention to other facilities. And so other systems manage that much more closely. In the US, we generally saw each delivery system trying to sort of do their own triage and basically take care of everybody, COVID and non, at the same time. And so what you saw really was that in certain states and certain counties, they they would simply need to shut down services, and they'd say, we're not accepting, we're doing no elective procedures. Elective here is basically means anything planned, right? And so just depending on where you lived, you may or may not have access to any services at any given point. There was really very little centralized management. And so those are sort of the direct effects that patients felt, but I think these last three actually turned out to be the underpinnings of most of our findings, which were how well countries set up systems to make decisions, to understand the data that they needed to guide those decisions, and then to communicate both among the healthcare system and to the public. And so on the decision-making front, one of the things that we were looking for was how well are countries coordinating between their levels of government. And I think what we found was countries that had centralized decision-making structures performed much better. Now, I do not mean to suggest that all decisions were made at the national level, but simply the act of creating an infrastructure by which you identify who is making which decisions should be made locally, which decisions should be made at a given hospital or health system, and which decisions are being made nationally, was incredibly important in countries that were able to be more nimble, more responsive, and really just know who was in charge. By contrast, in the US, we had a lot of countries that were really just waiting for guidance, right? Of course, we're going to get guidance from our health department. Of course, the Centers for Disease Control are going to tell us what to do. And they waited too long before figuring out that guidance wasn't coming. So I think the act of really being adaptive and designating decision-making to different entities is key. And that's the countries that did that better, particularly with sort of coordinating committees that included both local and national governments, were much more effective. Data systems, this is a place where I think all of you in Europe are in much better position than the US. I can't really underscore how poor and non-interoperable our data systems are here. But to the extent that anyone was trying to manage centrally, there was absolutely no information to guide those decisions. And so in other countries, you saw that very quickly standing up COVID dashboards to both track infection rates as well as delivery system capacity. Had we had decision-making structures in place here to try to guide resources to one place or the other, we wouldn't have known where to send them. We didn't have that information. And to be honest, I don't know that we've made a lot of progress on that yet. And then lastly, I'll mention communication. And particularly as we have seen the way that vaccine hesitancy has taken hold in the US, this has sort of really, in my view, been tied to communication. So I'll point to Australia as the country that we saw really do the best at this. And there, the federal government said, we're not making all the decisions, we're not doing all the implementation, but we are going to be the unified voice for communicating with our healthcare workers, with our public. And so they delivered regular, consistent messaging and therefore saw a lot less confusion, I think, both from the delivery system and from their citizens. And so I think, again, thinking very closely about who the appropriate communicator is and how to make sure those messages are aligned and consistent, if not entirely uniform, was another key to success. I'll leave it there and look forward to the questions.
Thank you very much, Caroline. I'm just intrigued in something you said right at the beginning about the difference of response that you saw in Asian countries. And given the fact that some Asian countries did have forewarning, they'd seen this before with SARS and MERS, what kind of head start do you think that gave, and did it really last?
Yeah, I think, that's the sustain piece. I think everyone has struggled with that sustain piece, but I think you've seen the Asian countries have an advantage relatively throughout. And again, this is where the public policy ties in. They understood the magnitude of the threat. They understood how respiratory diseases are transmitted, and they took strong, swift action to try to address that. Now, the challenge, right, is getting folks to adhere to that kind of restriction for a long period of time. And we've certainly seen challenges everywhere, including Asia, on that. But I think that awareness, more than the actual plans, right, but that awareness and ability to move quickly was certainly an advantage.
Very helpful. Thank you so much, Caroline. So we've got three panelists, and we have some time now for reflections from the UK point of view. And I'm going to turn to Hugh for some thoughts. Thanks.
Thanks, Jennifer. And thanks, everyone. These were such rich, good presentations. I've tried to, as we've gone, note down what I think some of the main points or reflections might be from the UK perspective. But I won't have done it all justice. But I thought there were five things. Yes, five things that I thought were particularly important. The first one is somewhat obvious, but I think underplayed from the English perspective often, is that there's obviously been very wide differences in COVID impacts, as the slides Mark showed. But there's been so many similarities in the health system responses and the challenges we now face in recovering. Most countries had to free up significant resources to strengthen the health system, tried to free up staff, used remote consults, had to cancel a ton of planned other types of care. Most countries now face disruption of services, though the size of the backlog seems to vary quite widely. So the upshot for us is that the problems, the issues we're facing here are not so unique, and we can do a lot to learn from other countries. The issues are also not that new often. So exacerbating our existing backlog in the English context, exacerbating existing staff shortages, widening existing inequalities. So that's the first point. The second, which I think the frameworks that all of the three speakers talked about illustrate, is that the resilience of different countries' health systems appears to be about the interaction between what came before, the preparedness, the context, and the ongoing immediate response. And as Mark says, will be about the recovery and the choices policymakers about recovering services. And the one area in England, the UK context, is still particularly important is people, staff. So you look at those charts Mark showed. Yeah, we entered the pandemic with fewer doctors, fewer nurses, fewer hospital beds, equipment per person than many comparable countries. We had staffing gaps of about 100,000. So it meant we were in a very different position to countries like Norway, Switzerland, Germany, if I remember from your slide right, Mark, that had relatively high numbers of docs, nurses. So the underlying lack of capacity meant some big trade-offs in terms of COVID, non-COVID care contributed to this big backlog. However much you spend, you can't magic up skilled staff. And we're seeing that now. You can build field hospitals very quickly. Lots of countries did. You can't just build a nurse just like that or a doctor just like that. So that our systems are going to carry on struggling to be resilient if we carry on lacking a long-term plan for staffing. The third big point that I think came out a little bit, but I was actually expecting to be a bit stronger, was that clearly our healthcare system can't be resilient if our social care or long-term care systems aren't resilient. And I think we saw that from looking at different country responses quite strongly. In England, so our social care system going into the pandemic still is a sort of threadbare safety net, really providing publicly funded care only to people with very high needs, low means. Again, staff shortage high, pay low. And our policy objective at the start of the pandemic was very explicitly to protect the healthcare system. In contrast, action to protect social care was slow, ultimately inadequate, and a lack of attention to the interaction between those two sectors. So I think something that we learned and echoed a little bit in what Joseph was saying was that your healthcare system can't be resilient if your social care system isn't resilient. Which links to the fourth point that I think was strongly echoed and very relevant for us here, is that, again, the health system can't be resilient if the underlying health of the population is not resilient. It depends on wider structural factors shaping health inequalities. So again, we entered the pandemic with stalling life expectancy, growing health gaps. We had a sort of decade of austerity in public spending, which affected the support available for people during the pandemic. It affected the success of other public health interventions. I think Joseph mentioned, so a lack of financial protections here and in some other countries undermine the ability of people to self-isolate, for instance. So the healthcare system resilience is closely linked to social resilience more broadly. And the risk when we think about recovery is that we look at the healthcare system too narrowly. Final reflection, standing back for England, I think, is what this all means or doesn't mean, probably more importantly, for reform. So the English NHS is clearly under huge strain, big challenge to recover services, not just in hospitals, but outside of hospitals as well. And we've made a big investment in our COVID response in the NHS, and government, the Treasury, is keen clearly to see the results from that investment. And I think in some parts of the political, the policy world, those things, the combination of investment, big challenges, have helped up the volume on what is, a usual low hum of debate about whether the NHS needs more fundamental structural reform. But I think the experience of the pandemic actually points to a very different set of lessons about reform, which is the kind of national policy approach the NHS needs. It's not really about admin or structural change or top-down reforms, the way the system works. It's about the blend of investment, expanding staffing capacity, support and the skills for the workforce, skill mix, like Joseph talked about, how to use data to design services, redesign services. It's a much more boring but important blend of levers. That's what we need to be focusing our attention on as we think about recovery, and not wasting energy thinking about big structural changes. We've already got some coming in the NHS, some organizational changes, and the risk is we miss the sort of management, cultural, intersectoral changes that we need, which is, if we think about top-down change being the answer, we're relying on a pretty faulty logic about how the system's going to recover, how it's going to improve. There were other lessons there about governance that we can get into, but Jennifer, I thought those 5 things were probably the meatiest reflections for us.
Very meaty. Thank you very much, Hugh. I thought the last point was particularly interesting because if you think about it, as I think Joseph was saying earlier, or Mark, it's going to take a long time for us to really digest all of these lessons. So whatever we do with our inquiries in different countries or international learnings, that's going to take a few years, isn't it? Meantime, the political timetable can be quite short because of the backlog, which is creating some fruity political challenges. So I guess there's a question for everybody on the panel, but I'll start off with you, Hugh, last in line, as it were, is whether or not you think the political timetable that something must be done in the light of chronic waiting times, and indeed a backlog in other services as well for chronic diseases and for mental health and so on, whether you think we're just going to be overcome by events and the pressure for reform will gather pace before we can really learn anything much about the pandemic.
I think we've got to try and push pressure in the other direction. We think about our backlog; it's going to grow before it gets smaller. It's very, very uncertain how big it's going to grow. IFS have done some neat estimates, but even the NHS's own plan is that we're expecting these things not to reduce until 2024. So the idea that within the current political timetable, things are going to be fixed for the birds is nonsense. And so we've got to start seeing the recovery as a very long-term game, which we can make progress on if we try and expand staff we have in the health system, if we invest in the right place. But this is the sort of the emphasis on a short-term political win, and something that what are the levers that policymakers can pull now is quite attractive, because you want to show that you're doing something as a leader. Often you want to be able to show that shutting down this agency, recreating these ones are going to help. But actually it's things like having a long-term plan for expanding our health workforce. It's going to have the biggest difference on recovering services. That's not something that we're going to fix in 1 year's time, 2 years' time, but that's where we're going to have a big impact. So I think we need to take the heat out of some of this debate, depoliticize it a little bit, and emphasize these are long-term challenges that require long-term policy making. It's challenging, but I think that we've got to try and take a bit of the heat out of the short-termism.
Yes, thank you. So just turning to Mark, Caroline and Joseph, do you see there political pressures in some health systems because of the backlog that might then result in over hasty, bigger changes to healthcare systems, in a sense, before we can learn fully the effect of the lessons from the pandemic? Perhaps if I start off with Mark.
I think I agreed with everything that you said, and yet I think I disagree with his conclusion. Absolutely, we need to be thinking about the long term. Absolutely, we're not going to solve this in the short term. But the thing is, we're coming out of a massive economic crisis as well. Yeah. And what we're seeing across Europe, across all sorts of countries, are these big, huge plans. Especially in Europe, but you've seen them everywhere, about how we can build back better. And you look at the details of these plans, green is everywhere, digital is everywhere. health isn't. Why not? This was a health crisis, wasn't it? It's exposed lots of problems in our health system. And yet somehow in the recovery plans, health is being forgotten. And that's a massive, massive problem for health systems in the future. My last slide, I talked about that 1.5% of GDP needed to have more resilient health systems. You can disagree with that or not, because absolutely, Hugh, I agree. Don't go down the route of thinking that there's a lever and we can reform the system and restructure the NHS again and that will solve everything. No, not that. But we do need more money. We do need a digital health system that actually works much better. We do need to replace some of the crumbling infrastructure, and we certainly do need a lot more primary care physicians and nurses out there. And if we don't get the spending now, a few years' time, we're going to be in another austerity era. I pretty much.
Yeah.
I mean, it's now. We need to get the health up there and the spending now. So everything you said, I agree with you, except that conclusion. It needs to be now that we get the political effort to spend more.
Joseph, isn't there public pressure because of the backlog to spend more?
I couldn't agree more. Mark. You're still the funder of what exactly I want to get there. Exactly. I agree with you, but I don't agree. We don't have 2 years. We don't need to learn anything. Sorry, I'm gonna just be a bit more controversial. Everything we learned from the pandemic, we knew. Shall we talk about the financial crisis and our human resources? Shall we talk about the fact that many of them got their salaries, their incomes sliced by 30, 40%? They have not even recovered. Have we talked about the disaster in some of the infrastructures that didn't have an investment? What has happened with the COVID and the next one is worsening a situation. It would worry me that that is translated, echoing Mark, into yet another set of reforms. What we need is more money, directed it to the human resources, the health workforce, training, better conditions. We have a whole list. If you look at some of our articles about conditions, some of them are financial bonuses, like we've seen in some countries. Some of them, better working conditions, better training, mental health support. There's been a huge amount of innovation in supporting the workforce that we need to harness, and we don't have 2 years. I'm a bit more optimistic than you, Mark. I like to be optimistic, depending on the day. If you call me tomorrow, perhaps I'm not. Today, I'm more optimistic that perhaps the international movement with Ukraine maybe will lose visibility. But with international movement now, with the International Pandemic Treaty, the European Health Union movement, which will affect the UK as well, the whole debate on the G20, trying to liken the issue of the One Health, the issue of international governance, with the issues of environmental health. So if some of these instruments, I recommend you to look at the Monti Commission. We were in the scientific board, was the co-chair, and Mark was there as well. Is put forward a series of instruments that are not new, but I hope with the real crisis we've gone through will be adopted. And a lot of that is working together across boundaries. So there's an element of national investments indeed, but it's national investments in the health workforce, indeed the digital, although the digital, Mark, to me, is more on the regulation, is more on the training, is more on the change of culture, more on the incentives than necessarily lots of fancy digital developments. But anyway, may as it be. Anyway, I'll leave it there because there's lots of things to say. Sorry.
Thank you, Caroline. It's difficult to imagine that in the US that people can argue for more spending on healthcare. But you said some very strong remarks about the resilience of the healthcare system and how effectively a lot of nursing staff have been exploited. And anyone listening to the New York Times daily podcast will hear this from the very front line, nurses who are just utterly, utterly burned out and shattered. I just wondered what you thought then, some of the lessons would be about reform. Is there going to be any push for reform of the delivery system in the US as off the back of the pandemic?
I think the answer is actually the same as Mark and Joseph. We need to take advantage of any shred of momentum we have left to try to address what we saw as huge holes in the system during the pandemic. And my deep fear is actually that everyone in the US and globally wants to move on. And so I think we risk not capitalizing on the crisis that we are still enduring because everyone is tired. And I don't think there's much to learn. I think that, the holes are holes that we've known about, and we sort of tested how bad they were and we saw that they were atrocious. And so now we need to fill them. But I'm not, I hold some shred of hope that the US might move forward. But I think health, we've talked about health for 2 years. People would like to talk about something else.
Thank you. I mean, looking at what Joseph just put on one of his slides, you know, what is needed, what are the learnings? You could have written that before the pandemic, as you say, Joseph. So how do we land some messages about how the system could be more agile in future, even if governments don't want to spend more money on it? How could we cut through and maybe do stronger international comparisons that could cut through on a national stage? Because otherwise we'll just be having intelligent conversations, writing intelligent reports, won't we? Which is what we all try to do. And actually the whole political machinery's moved on. Hugh?
Yeah, I think it's by emphasizing, as this discussion does, that it's those underlying features of the health system. It's the levels of investment in staffing, it's the culture, it's the governance, it's use of data that have affected how well we've done and how well we've responded during the pandemic, less than the administrative structures, the levers that politicians might go to reform the system. We've got to emphasize that performance has been driven by how agile we've been at, expanding capacity, changing skill mix, amending our delivery system in these quite technical but really important ways. Which is sort of the point I'm trying to make about reform. We should focus on those underlying factors: investment in technology, investment in staff, rather than perhaps a more political version of reform that's more top down, looking for easy to pull levers. So I think it's by highlighting what we've learned, even if it's not new to us, it's an important message about what has really driven performance during the last 2 years.
Yeah, I wonder whether some of the messages might land, and some of the questions here refer to this. If we could have taught or foreground digital, the need to invest in digital, clinical trials, and so on, because that's so linked to economic performance, isn't it? Rather than just healthcare staff just taking money out of the state the whole time, or taking, being a drain on resources. So I'm just wondering whether actually profiling more the benefits to having a rapid clinical trials infrastructure, as we showed in the UK. I thought we were pretty good on that, on vaccine development, on those sorts of things, could at least be a way in. And it's a positive message about the future, isn't it? Rather than just a total, we need more money to be more resilient kind of thing. I don't know if you have particular thoughts about that particular area, the science infrastructure. I know that's another huge area, but it is related, isn't it, to spending on healthcare, that we can have good clinical trials infrastructure.
I mean, that was something that I did talk about a bit in the chat, and I do think that's an area where, there's a risk in these sort of events. We end up hammering how awful the UK system is, because of course we see, I mean, you lot all see it much more closely than I do, but that is an area where it's worth celebrating how well the UK did during the pandemic. A huge amount of the clinical breakthroughs, clinical understanding of how to manage the disease came from the UK. And in fact, it's a worry globally that so much of the evidence came from such a small number of countries. The UK, the US, bits of Swedish, bit of Dutch, but not an awful lot coming out from Japan, France, Germany, those countries. And I think globally that's a problem. And we should be doing better in those countries. So that's one thing I'd say. But Jennifer, I do think that this issue about just focusing on the clinical, yes, there's lots of things that we can do better in terms of getting the data to make clinical breakthroughs. It's true. But we don't use the data in a way for non-clinical decision making, even though there's obvious enormous payoffs. I mean, the amount of time that it took early on in the pandemic just to get some sort of idea about how many emergency acute care beds were being occupied. And, we had people picking up the phone and ringing acute care wards to try and find out what the bed occupancy was. I mean, this is not the way to manage a pandemic. We were finding out information on capacity a week or more after we needed the information. That's not acceptable.
So that speaks to the need to step up agility, including information flows. Very important. Anyone else want to respond to their clinical trials point, or the way to go into this to learn lessons would be to foreground some of the economic positivities of investment in future that would add to resilience? Caroline.
Well, I think what's interesting is actually that, we did well on the hard stuff, the science and getting vaccines brought to bear faster than we've ever seen, right? That's all the hard stuff. What we're talking about, figuring out bed occupancy in every hospital in the country, and training a workforce that has existed for centuries is not hard, right? But
yeah.
It's not sexy, and it has to be prioritized, because what we found is actually we could do the really hard, fancy science stuff, but we didn't have the underlying boring infrastructure to make it as impactful and meaningful as it should have been.
Thank you.
I think we can learn a lot on the way that research has been a bit of a public good for a while, the way that the results were released, were shared. I'm in a naive stage today, but I do believe that there is a strong argument for building critical mass on research. There's so much duplication in the European Union countries, actually, among themselves. I do hope that not at the EU, but international level, we'll see much more of that building critical mass around research, non-duplication, releasing. I know it's naive. I know all the vested interest there. But I think I'm slightly positive about being able to work together and react much better next time round. Indeed, I think the HERA, the reforms of EMA in the European Union countries will make a huge difference in terms of the rapidity of response and going faster with the clinical trials, approving new treatments and so on. I think that's the way to go, really. And that's one of the positive things of the pandemic.
Great stuff, thank you. You've anticipated what I was going to ask you, because we're amazingly running out of time. We've only got 8 minutes left. Can you believe that? So maybe if I just go around to you all very quickly to say, I think, what are the top 3 lessons you think we've learned so far? And I think the fourth thing is just if you could say where you think the hope is then for us, what's the best hope for us to learn from these last 2 years together internationally that might have a hope of landing on governments as opposed to bouncing off walls of granite? So perhaps if I can start off with Mark, I'll go with you first.
Sorry, I was in the middle of typing a response. I love typing the answers to all these questions. Sorry about that. The 3 things to learn, my 3 would be digital, workforce, and social care. I think they were the 3 areas, frankly. What I would want to learn going forward. I think some of these governance issues are absolutely right. There's a risk that our reaction to this crisis will be that we prepare plans which would have helped us respond to this particular crisis much better in the future. And that won't work. We're not going to get the same crisis. It's going to be a different set of challenges. This standard thing about known unknowns and unknown unknowns. We need to be ready for the unknown unknowns.
Yeah.
And some of those things that Caroline was talking about being clear about what decisions are going to be made at what level. So what is it that the hospital makes, the primary care makes, what's the local government's responsibility, state governments when you have them, and national public health authorities. Those things, it turned out, weren't very clear in virtually any country. There were some countries were better. So that's what I'd say.
Very good. Thank you so much. Caroline.
I think, one lesson is that people are a very valuable resource. And I think actually as we've become more technologically advanced, we have forgotten that a little bit. But the importance of nurses and doctors and other healthcare workers in direct care remains. And so I think we need to re-examine and re-elevate the humans in our system. I think I would underscore the decision-making point that Mark just raised, mostly because it applies across crises, right? We may have another respiratory pandemic, but we're more likely to have some other crisis, and building those muscles of decision-making and clarity will serve us well. So I think those would be the 2. And then my sort of look ahead hope again is that we actually act. We don't move on, but we take action. The lessons are pretty clear. And much of how we stood up telehealth so quickly is because we knew what we needed to do and the technology existed. That's true of most of the things that we've talked about today. And so we just need to do them.
Very good. Thank you so much. Jason.
As my colleagues have already covered some of the points, let me add another three. Actually, I feel quite strong, from the very basic to the national to the, for the delivery to the national to international. On the delivery side is primary healthcare. I know it's a topical, stereotypical almost, but really, either we strengthen that or we don't survive. You know, we used to use, Jennifer, we used to talk about the UK or England and the Netherlands as the countries where primary care was well considered, there was pride, there was interest, they were well paid, it was working well. Now we're seeing these two countries also with enormous crisis. Actually, The Guardian had an excellent paper by a GP explaining and sharing what is to be a GP these days. So we need to prioritize that. Number two, the beautiful thing about the virus is that it's called the bluff of populists. So it really, we learn about communication, transparency. We cannot bluff. We need to understand social network. We need to understand the social media. We need to communicate much more transparently, much more humbly. I think on the overall governance, communication is one of the most important areas. The failures of the vaccination is a very good example in some countries. So I hope that's the second area of learning. The third area, I hope that some countries will understand, I said that already, let me repeat it, that you have to give away some sovereignty, because health is no longer about well-being and the economy and all these things we've been talking for years, Mark, I know many of us. It's also about security. And it's not only the viruses, it's universal coverage, health coverage in other parts of the world, is security, because it's refugees, it's migration, it's unrest, it's war. So I think, and I hope, I'm a positive day today, as I said, that this goes at that level, that health is security, and we need to invest on that. And the next one, which is antimicrobial resistance coming, is going to kill us all. Sorry, I'm exaggerating, but you know the numbers. You know the numbers. I'm trying to, you know the numbers. And the next one will need even better and more integrated coordination at a broader international level.
Thank you, Joseph. Good. The final word to Hugh. You've got 6
minutes. I'll be quick. So three things. First, as everybody said, the workforce. We've got to take a long-term approach to planning the workforce. Second, social care, a system in England anyway, much more in need of reform than our NHS. We thought we'd learned that lesson maybe a year ago. It looks like we've already forgotten. The third is this has ultimately been a political response as well as a health system response, about trust, values, communication, and fundamentally, you know, not letting events outpace our ability to govern ourselves, which they have done at times. So we should really emphasize the political dimensions of the response. And then finally, looking to the future, we should do much more to learn about how we change services so quickly in different contexts, and which things might work for the future, which things might not work for the future. So focusing on those service changes and how they happen in different contexts.
Thank you so much, Hugh. I'm afraid we're probably going to get the kibosh coming down in 60 seconds, so I'll better speak fast. Just to thank our speakers very, very much. This one is going to run and run, isn't it? This webinar, we're going to obviously have to send to Baroness Hallett, who is the chief of the new inquiry, as to what happened in the UK. But thank you very much to our speakers for all their insights. We'll come to this back to this again. Thanks to the comms team for their support. Thank you to all of you for watching and your questions. And if you like this, then you might like our other webinars. Please sign up to our newsletter here, and you can get advance notice of all the lovely things that are going to come up and be discussed. Check our website, lots more material on the pandemic put together, and I hope you enjoy that. And if you haven't checked out our monthly podcast, please do that as well. This month is on drug deaths and rising drug deaths and what to do about it. So thank you so much. A bit rushed, but I think we covered some very good contours. Thanks to our guests. That's all for now. Please stay well and look forward to seeing you next time. Thank you.